Hi there, my name is Vic Veer. I am an ENT surgeon. I'm the head of the sleep surgery department at the Royal National ENT Hospital in central London. Now what that means is I normally work with people, or I perform operations on people who have obstructive sleep apnea. So this video is actually more pointed towards doctors rather than other people. So if you're interested, please do carry on watching. But it's mainly for doctors, mainly anaesthetists and surgeons who are interested in operating on these sorts of patients. Because what I want to tell you about is some safety tips that over the years myself and a fabulous anaesthetist called Jim Roberts have put together, along with people like Pete Thomas and Michael, all sorts of people in our department, along with the pain management team and other departments at UCLH, who have come together, put together a sort of a plan to help patients get through an operation. Because when you have obstructive sleep apnea, the risks, the morbidities, mortality is all much higher for people with this condition when they're having an operation. Hopefully some of this advice may be useful to people out there just to make things safer, cause less distress for these patients, and hopefully we can make their experience a bit better as well. Obviously this is just broad strokes. I'm not giving you a protocol that you have to stick by or an algorithm. All I'm doing is giving you a few tips that might help you. And at the end of this video, if you want to keep watching to the end, myself and Jim Roberts are going to put together some sort of course, and I'll tell you about that later. So the pre-assessment clinic means the clinic that you go to prior to your operation, just to make sure that you're fit enough for an operation. Now, the first thing to say is that I'm not just talking about obstructive sleep apnea patients having an operation for their sleep apnea. This is also people who are having a knee replacement or a hip replacement. A lot of these people have obstructive sleep apnea. People who are very large, who need bariatric surgery, they often have obstructive sleep apnea as well. This is for all sorts of people who may be going through the pre-assessment clinic. A lot of people use the Epworth score. It's a score of daytime tiredness. But please don't use that when you're screening for someone with obstructive sleep apnea. It's not been validated for that use at all. It is useful when you're trying to decide whether they should have CPAP or not, and other indicators to see if they're getting better. But it's not a good screening tool. It's almost useless as a screening tool because it's about tiredness, and some people with obstructive sleep apnea sleep more to get away with, so they're not tired during the day, and there's all sorts of problems with that score. I should actually do another video on Epworth score and how bad it is in terms of screening. But what you should be using is something called the Stop Bang website. There's a website, free website, with a calculation that's done it. You fill out the 8 questions, it comes out with a score at the other end. If you have intermediate or high chance of having sleep apnea, you should then go on to have a sleep study before your operation, just to make sure you don't have obstructive sleep apnea. The Stop Bang questionnaire screening test has been validated for obstructive sleep apnea. It works as a screening test, so use that. Don't use any of the other things. Obviously, most sleep operations, we've already done a sleep study. We know that they've got obstructive sleep apnea, so this doesn't really relate to that. It relates to other people who we're not sure whether or not they have obstructive sleep apnea. And if you find someone with obstructive sleep apnea, you need to keep them overnight. Often in some hospitals they say that you need HDU or ITU support afterwards. There would often be a sort of a rules and protocols for people with obstructive sleep apnea. You just need to follow that once you've done their sleep study. But if you know that someone's got obstructive sleep apnea, and even though they say, look, I'm not diabetic, I don't have high blood pressure and things like that, they often do, because obstructive sleep apnea causes these things. So it is worth getting those things checked, HbA1c, doing a chest x-ray to see if they've got any large heart, or even an echo, because echoes will pick up things like pulmonary hypertension and things like that as well. So it's really useful to have a really close view at these patients, because they often have undiagnosed problems. If possible in the pre-assessment clinic, particularly if an anaesthetist is talking to the patient, it is useful to tell the patient, look, you may not be using CPAP because you find it difficult to use, but if you're having an operation and having untreated obstructive sleep apnea, your risk of morbidity, mortality, and the surgical success is much lower. Even if you can just encourage them to use CPAP for the 3 months prior to an operation and a few months afterwards as well, just to get them through the operation, at least that's better than nothing. And it might also focus their mind a bit about how much danger that they're in terms of their obstructive sleep apnea and then having an operation. So hopefully that will help them as well, and refer them to a sleep centre. Hopefully they'll be able to be treated quickly, and they'll come back in a much more optimised way for their operation. So now we come to the operation day, and we do our consenting, we talk to the patients beforehand. But for obstructive sleep apnea patients, particularly in the moderate to severe end of the scale, even if they're using CPAP, you've got to be aware that these people have rather interesting airways. If you imagine they can't keep their airway open at night, even just by falling asleep. When you give these people an anaesthetic, everything is going to collapse down. It's going to be much, much harder for you to intubate these patients. So I really think with the surgeon involved and ODP, everyone has to be around. and you sort out a proper plan to help gain an airway in these patients once you've anaesthetised them. Now, a lot of people already know this, but it is worth mentioning because some people are unsure. Sometimes you can look at someone and think, actually, I think they might have sleep apnea. Sometimes they say, yeah, I just snore really loudly. But if you think that they've got obstructive sleep apnea that hasn't been picked up and you have to go ahead with an operation anyway, then have a plan with what to do about these patients. Because often people go, well, let's just try a Macintosh curved blade and see what happens. But that's often very difficult to use in these sorts of patients. And some people rely on a CMAC blade or video laryngoscope, and they go, oh, I can't even see it with this. A lot of people with obstructive sleep apnea find it very difficult. You find it very difficult to get an airway with a CMAC. Jim Roberts, my anaesthetist, thinks about this. He often has I think he calls it a Miller 2 or a straight blade technique, because the tongue just isn't in the right place, and these people have slightly recessed jaws and other problems, like a perfect storm when it comes to airway, losing an airway. Having a straight bladed technique, going into the glossotonsillar fossa, pushing the tongue out the way so you can see the airway from the side rather than going right down the middle. There's all sorts of little techniques we can that should be employed, and have a plan for all of these so that you're not like, oh God, what do we do now? Go and get that blade, and there's a patient who isn't getting ventilated at the same time. So it is really useful to not rely on a video laryngoscope and have a straight blade around, or have, if you've got an ENT surgeon around, maybe employ them just in case to get one of their straight bladed endoscopes and things like that to get to the airway so you can pass a bougie down and then get your tubes in. So just be wary that these are difficult airways. Now, the next section is about how you anaesthetise these patients. Now, it may be rather galling for anaesthetists watching this to say, well, what's this surgeon telling me how to anaesthetise a patient? And apologies if I get this all wrong, because this is just me translating from my friend Jim Roberts. So if I get this all wrong, I'm really sorry. But hopefully you'll understand what I mean, and you'll get the message I'm putting across. So the first thing we do is we pre-oxygenate our patients. We sit the patients up, we put the oxygen on, and we wait for the end-tidal PO2 to get better to the point where we're pretty sure that there is oxygenated as much as we possibly can. And then we lie them down and we start the thing that you guys normally do as anaesthetists. Now, often my anaesthetists use rocuronium or vecuronium because it's easily reversed with Sigamadex, although it is slightly expensive. But it's worth it if you're talking about safety for the patient. For ENT operations, we tend to use a relatively small armoured tube, so we can work around that. So because it's a shared airway, we need to work around the tubes that you have in the throat. And because some of these patients are quite large and they have something known as obesity hyperventilation syndrome, where basically there's a lot of weight on their chest, and so they find it hard to take a deep breath in because they've got all this weight to push against. And when you're anaesthetised, everything, all that weight, it's almost like dead weight on their chest. It's quite hard to get an airway. The air just sort of rushes right out, and you get into a situation where you think you've got an awful lot of time, but you really don't. When you're giving positive pressure airway support, you need an awful lot of pressure to expand those lungs against the weight of that chest. So just be careful you don't give too much and you end up with a pneumothorax, and that's been heard of before as well. I guess a lot of you know that with bariatric patients as well, but it's worth remembering even for the obstructive sleep apnea patients. Now, extubation, of removing the tube so we can wake this patient up so they can breathe normally by themselves, is quite a dangerous position to be in this situation, because a lot of these patients have an awful lot of secretions. They have, and because of those secretions, and because sometimes the airway surgery they have or the pain that they've had, a lot of them go into a laryngospasm. That means the voice box closes up and they can't breathe at all, and then the oxygen dips down very quickly. So there are a few techniques we use to try and avoid this situation. Some people use glycopyrrolate. We tend to just suction out the secretions before we start. But think about the secretions. But the laryngospasm can be very difficult and can lead to really scary situations. So there is a bit of a balancing act here. You don't want to wake up these patients too light, because if you do, they wake up and pull out their tube and that causes laryngospasm. And equally, you don't want to wake them up too deep, because then you might lose the airway, because you have to try and find the airway again, and they're difficult airways to begin with. So the way Jim Roberts does it, he uses a Tiva remifentanil infusion and then lowers it down. So people are on very low dose remifentanil as they wake up, just to sort of soften the landing of these patients. But if you're using a volatile gas anaesthetic, you can pull out the tube and put in an LMA to try and soften that landing to avoid that laryngospasm. But you run the risk of losing the airway with the LMA. So whatever works for you, just be cognizant of that there are some issues with either way. We often spray the cords with local anaesthetic to avoid the laryngospasm, and I've also stopped using naceptin at the end of my septoplasty operations. Often these patients wake up and go like this, And that little bit of naceptin up the nose, which has got peanut oil in it, can get sucked into your lungs very quickly. And it seems, I've noticed, to set off a bit of a reaction. It seems like the lungs really hate peanuts, even in peanut oil form. So that, I think, also causes a laryngospasm. So I no longer give naceptin. There's no real need to give naceptin straight there and then. You can give it once they've woken up in recovery, because it's just an antibiotic cream. It will work if you wait 15, 20 minutes. So I've changed that in my practice to avoid that huge sniff that seems to cause some laryngospasm in these patients. I also talked about armoured tubes earlier, and you have to be a little bit careful, because some people, when they have laryngospasm, bite down on the tube really hard. And when you bite down on the tube, because it's armoured, it can get squashed and it stays in that position, it stays narrowed. So what we tend to do is wrap up some gauze and put some tape around it. It's big enough so it's almost like a cigar. And so they've got the tube coming out, and they keep the teeth apart by using this sort of gauze cigar. And so when they can pull out the tube or the LMA, whatever you want to call it, and then they can pull out the gauze to stop them from biting down on the tube. Now, with very large bariatric patients or weightlifters, very muscular patients, they often get this laryngospasm problem. So just be very careful with these patients. It may be worth using a drug such as clonidine just to soften the landing some more, so when they wake up they're just relaxed and they don't end up with this problem where you lose the airway, potentially giving them hypoxic brain damage. So as you know, some of these operations, like knee operations, hip operations, throat operations, when they're done on people with obstructive sleep apnea, it's very, very difficult to maintain their pain management, because you can't give opiates to these patients because they're very, very sensitive. That's why I think unfortunately some children have died in America because they were given codeine after their tonsils and adenoids were removed. So a lot of people have just banned the use of codeine around the world because of the codeine is 5% morphine. What we do is try and be as opiate sparing as much as possible. Instead of giving opiates, we give 0.3 to 0.5 milligrams of ketamine per kilo. And with that ketamine, which you give at the start of the anaesthetic rather than the end, because you'll get all the nasty side effects. You give it at the start of the anaesthetic. When they wake up, they're just far more sort of relaxed. You don't need so much opiates at all. In fact, I don't give any opiates. I tend to give, the recovery nurses give fentanyl in recovery, but we don't give any tramadol, codeine, morphine afterwards at all. It can be done because, particularly if you've got a well-secured sort of HDU environment, but a lot of these patients are sitting on the ward without one-to-one care. So just be careful of that sort of thing. We found that the ketamine helps these patients for about 48 hours, and at that point the pain starts kicking in as the effect of the ketamine wears off. But for those first 2 days, it's really, really useful to avoid them having opiates and getting them over the first few days of an operation. I tend to give a full dose of NSAIDs, either 800 milligrams 3 times a day of Nurofen or 50 milligrams 3 times a day of diclofenac, although a lot of people don't like NSAIDs or diclofenac anymore. But it is, for throat operations, the best sort of drugs. Around the world, although we don't use it very often in this country, a lot of people also use gargled aspirin to stop the pain in their throat if they've had a big throat operation like tonsillectomy or things like UPPs, which not many people do anymore. But those sorts of operations, you can use a dissolved aspirin. In this country, we're a bit scared of dissolved aspirin because it causes bleeding, although as far as I can tell, there is no data out there that shows that using dissolved aspirin in tonsil operations seems to increase the rate of bleeding, unless they swallowed the aspirin, obviously. If you really must give opiates to a patient and you really have no other choice, we found that DF118 and tramadol seems to be quite useful, but be careful, because you can get into a bad situation, just like you can with a PCA. There are there's loads of patients in the world who've had a PCA, and because they've had obstructive sleep apnea, they've unfortunately died because of the use of a PCA. So just be careful of that. Really, I don't like to give any opiates at all for obstructive sleep apnea patients. I just don't think it's safe enough. In recovery, on the ward after the operation, a lot of these patients stay for a day or so because, at least in the UK, people with obstructive sleep apnea need to stay the night because there's a chance of pulmonary edema, which can, particularly in sort of children with obstructive sleep apnea, can occur up to 48 hours afterwards. This is the compensatory pulmonary hypertension that's caused by the obstructive sleep apnea. When you remove the tonsils in children, things like that, suddenly they get pulmonary edema and they start not being able to breathe very well. And that's why, with very, very severe children, you need a PICU or a sort of central unit to be able to look after these children who are likely to go into pulmonary edema after a tonsillectomy operation, which is why we keep oxygen on their finger, oxygen saturations monitor on their fingers over the first night or two. If they do well in the first night, they can just go home, obviously. But we tell parents that just be careful that a child may have problems afterwards. And we often give these children steroids because that works quite well with pulmonary edema. Very, very occasionally they need to be intubated and put back onto a unit, an intensive care unit, if they get into this problem. I haven't seen that for years now, but it's something to be aware of. We don't want that to happen to anyone. Now, I'm sure you're all getting very bored of this video. I'm sorry you've had to go on and on. Jim Roberts and I are going to do a proper video or a course about this at some point for people who are interested in this sort of issue. We've done a lot of research into this, and hopefully this could be useful to people out there if they're interested in coming onto this online course. Do take care. Thank you very much. Bye-bye.